Hello, everyone. Can you guys hear me?
Yes.
Yes.
Okay, so guys, today we will be starting. My name is Muaz, and today we will be starting our new topic of reproductive embryology. So, first of all, we need to know about some genes that are really important for embryogenesis. So,
Or with your lecture, we should follow pathoma or first aid.
since we are starting from the embryology, embryo part of reproductive system, so it will be from first aid.
Okay, thank you.
Okay. Okay. So, there are some important genes that we need to know about in reproductive system and in embryogenesis. So, the first important gene is homeobox gene, which is known as Hox genes. And these genes are important as in your exam, there will be some questions about embryogenesis and the problems regarding embryogenesis, the substances or the conditions which cause those problems in embryogenesis and what genes are affected in those problems. So first of all, we have a gene known as Hox gene. So what is the function of Hox gene? Basically, Hox gene is involved in the formation of limbs. So it will form your arms and legs of a baby. So what causes a mutation in Hox gene? And whenever there will be a mutation in Hox gene or homeobox gene, there will be a problem of arms and legs. So that gene, that substance is known as isotretinoin. Can anyone tell me why do we use isotretinoin?
Acne.
Yes, exactly.
The
So
vitamin
for
A
ref
use.
refractory acne or acne vulgaris, we tend to use isotretinoin, and it is very good in the treatment of acne. So, uh, what does the guidelines say regarding isotretinoin? This is a very important thing, and they love
You
to
should
test
use
you.
like a contraceptive if you're using isotretinoin.
Yes, and other important thing is the thing that most of students miss, that the contraceptives should be double. So you won't use a single contraceptive with isotretinoin. So you always have to use a double contraceptive. So if you are using a pill or if you are using an IUD, you have to add barrier contraception as well. So barrier contraception means some kind of spermicide or some kind of condom or some kind of vaginal cap. So whenever you use isotretinoin, you have to use a double contraception, which is known as barrier plus a pill or barrier plus IUD contraception. So the other important thing is before starting isotretinoin, you also have to do one other thing that they will confuse you with. So if they say in your question that a woman is starting a treatment for acne and we will be starting her on a drug known as isotretinoin, what is the following thing that you need to do? And if they have already mentioned that the patient is taking two kind of contraception, and what else do you want to do with that person before starting isotretinoin? Anyone?
I think checking LFT, I'm not sure.
Yes,
Liquid
that is
profile.
important. No, a very important thing that all of you are missing, and that
You
is a
can't
very
solve the
important
question.
exam question.
Ask the patient whether is pregnant.
Yes, exactly. So all of you have to check for HCG. So you have to check for HCG in the urine. You have to check if the patient is pregnant or not. So first of all, you will check if the patient is pregnant or not, because if and then you will start on barrier contraception and the pill contraception, and then and only then you can give the patient isotretinoin. So these are some important recommendations or guidelines regarding isotretinoin that you guys have to remember. Okay, so remember that isotretinoin will cause limb malformations. So they can give you a question. So they won't directly give you that the patient use isotretinoin. They can give you a question that a patient came to you and she was pregnant and now her baby is born and she has and the baby has some limb problems and the patient took treatment for some kind of dermatological condition. So you have to think that whenever a treatment for any kind of dermatological condition is given, always keep acne in mind and always keep isotretinoin in mind and know that it can cause limb malformations in the baby as well. Okay, so the next important gene is SHH, sonic hedgehog gene. This is another important gene. Why? Because it is involved in CNS development. As you guys have already completed neurology, what mutations in sonic hedgehog gene will lead to what problem? Can anyone tell me?
Atresia.
Yes. So, sonic hedgehog gene mutations will lead to holoprosencephaly. And what is holoprosencephaly? The diagnostic clue, the main thing that will lead to holoprosencephaly to you in a question would be a single eye. So, if the patient is born with a single eye, yes. So remember, S stands for sonic hedgehog and S stands for single eye. So remember, it's a single eye and it's S. So always remember this mnemonic for sonic hedgehog gene. Whenever there is a problem of sonic hedgehog gene that causes CNS development, there will be holoprosencephaly. And holoprosencephaly again is a very important concept and very important disease that we love to test. So first of all, we read about the homeobox genes and now we read about the sonic hedgehog gene. The third important gene that you need to remember is the fibroblast FGF gene, fibroblast growth factor. Can anyone tell me what does this gene cause? It's not written in the first step.
It's for the proximal to distal limb development.
Exactly. It's again, it will lead to some kind of limb problems, but what limb problem exactly?
Like the
And
limb
again, this is
buds
a
will develop
condition
on the
which
different.
this is a condition which is very common in the real world, and you will see a lot of kids and a lot of people with this problem. Has anyone watched Game of
Yes.
Thrones?
Yeah,
Yes.
achondroplasia.
Achondroplasia.
Yeah.
Yes.
So yes, exactly. So the Tyrion Lannister and that Peter Dinklage had achondroplasia. So any problem in FGF gene leads to achondroplasia. And what happens in achondroplasia? Basically, in achondroplasia, the cartilage remodeling is not completed. And when the cartilage remodeling is not completed, the bones will not form because a lot of bones form indirectly from cartilages. So whenever there is incomplete cartilage remodeling, bones won't form. And as a result, the limbs remain small. Remember, FGF gene will cause the development of limbs, not the whole body. So this is a very important thing. It will cause the development of limbs. And that is a very important thing about achondroplasia. So if this his or her limbs will be really small and the trunk or body does not form directly from the cartilage, so it won't be affected. So in achondroplasia, the main things that are affected are limbs. And what is the reason that the limbs are affected? It's due to a mutation in fibroblast FGFR gene. So it's fibroblast growth factor receptor gene. So the receptor for this gene is has a problem and that leads to achondroplasia and the baby will be really small. So whenever you're taking your USMLE exam, any NBME or any board exam, they can question you or test you in these ways. They will simply give you a question, they will simply give you a vignette. And the most important thing is you need to know how to diagnose these problems. So always keep in the back of your mind that if a baby has some kind of developmental problem and it is due to and the mother took some drugs for acne, or some kind of dermatological problem, and then that would be homeobox genes. And again, if the baby has some kind of CNS problems and they ask you for the gene would be sonic hedgehog gene. And again, if if there is problem with the height of the baby or the height of the boy or the child, and the limbs are relatively small as compared to the body, then it will be known as achondroplasia. Okay. Can anyone tell me the difference between achondroplasia and dwarfism?
Dwarfism is symmetrical shortening.
Yeah.
Okay. So what else
Achondroplasia,
will be
Dwarfism
achondroplasia?
is
Achondroplasia,
limb
because of
the
dorsal.
head is
hypothyroid.
normal. Sorry, head is normal.
In achondroplasia, the dorsal or the thorax is normal, but they have limb shortening.
And in the dwarf, the whole
Yeah,
body
exactly.
is
And what is the cause of dwarfism? And what is the cause of dwarfism?
Growth hormone, insufficiency
hypothyroidism.
of growth hormone.
Hypothyroidism. Yeah.
Hypothyroidism.
No, it's not hypothyroidism. It's hypopituitarism.
Insufficiency of
Achondroplasia
growth
is always
hormone.
Okay.
Growth
type of
factor
dwarfism.
deficiency.
Okay. Okay. And another question: what is the most common cause of hypopituitarism in children?
Craniopharyngioma.
Craniopharyngioma.
Pituitary
Exactly.
tumor.
Yes, exactly. So the most common cause of hypopituitarism in children is craniopharyngioma. So craniopharyngiomas will lead to dwarfism in children. Okay. Okay. Now another important thing is you need to remember is that so let's start with the early embryonic development, and they can ask you a lot of questions regarding this, and they can basically integrate these things in any part of your exam. So what happens in week one of embryonic development? Can anyone tell me? Yes.
HCG secretion.
No, before that, it's incomplete in first aid.
Blastulation. Hmm?
Okay, so number one thing is let's go to the day zero. So first of all, the most important thing that happens is there will be a sperm and an egg. Can anyone tell me the number of chromosomes in the sperm and the egg?
1N.
3 in each.
23.
23.
2, 3.
Yes, it
23,
will be
1N.
1N. Yes, it's 1N and 2C. And it's 1N and 2C. And they both combine and they will form a zygote. So the number one thing that forms is zygote, and it will be 2N and 4C. So remember, a zygote will always be 2N and 4C. After that, there will be cleavage and the zygote will start dividing. And then the zygote forms a morula. And after the morula, on day 4, the most important thing is on day 4, if you see the diagram up there in the first aid, you can easily see that in the diagram. So a lot of things in first aid, remember this, and pathoma are only shown in the diagram or only found in the figures. They are not present in the text. So a lot of people, a lot of students miss those cues in the diagram. And when they get a question in the exam or NDME, they'll say that we did not see this question or this thing. So the point is a lot of things will be just in the diagram. So you will miss it. So if you see the diagram, you will see the first way that fertilization occurs. The oocyte is 1N and 2C and the sperm is 1N and 2C. Then there will be fertilization. That means the both the sperm and egg combines, and the zygote will form, which will be 2N and 2C. And on day 4, a morula will be formed. And remember, when the morula implants, it's become a blastocyst. That is a very important thing to remember. When a morula implants, it will become a blastocyst. So implanted morula is known as blastocyst and is so basically cyst and sticks means it's will implant on the day 6. So it implants on the day 6. And what is the most important thing about this? is that the day blastocyst starts to implant, HCG will begin to form. What is the full form of HCG?
Human
Human
chorionic
chorionic
gonadotropin.
Human chorionic gonadotropin.
Okay, so a thing, a way that they can test you in the exam indirectly is that they can tell you that a scientist is developing a test and he's checking for a special protein in the urine that is secreted and that causes uh, um, to know us about the pregnancy and whether a mother is pregnant or not. Which other process will be going on in the body at the same time that when this protein will begin to secrete? So they basically combine two procedures or two things which are going on at the same time, and they will give you this question. So always remember to combine two things to remember similar things which are happening at the same time. Huh? So HCG will start to form at the time of blastocyst formation. So that will be day 6. So remember, it will be day 6, and when HCG will begin to form at the same time, blastocyst will be implanted in the uterine wall. The second thing is that remember, you can only know that a woman is pregnant by urine pregnancy test on the day 6 after the woman had intercourse. So after 6 days of intercourse, you can know by HCG if the woman is pregnant or not, not before that. Before 6 days, if we go into the biostats, we can call it that it will be false negative. So before day 6, there will be no HCG and it will be false negative. In which thing of the human body do we check the HCG for?
It could be checked in serum and urine,
Yes,
but it will
so
be important in urine,
basically,
serum.
yes, the main thing that we'll check it in will be the urine. Okay, so what is the main function of HCG? That's another important thing.
To keep the placenta alive.
Why
It
is
maintains the
HCG
Resource
important?
monitoring.
so that
It makes the bed for
Hmm?
implantation.
it basically
And anything
maintains the
else?
corpus luteum that secretes the progesterone, which maintains the pregnancy.
Yeah, it maintains the progesterone
Okay, so how
production.
does
Mhm.
exactly? So the other important thing is that they love to test in exams is how does progesterone maintains the pregnancy?
Mhm.
Stimulates the spiral arteries and the mucous glands. They're supposed to feed
To
the
maintain the
zygote.
corpus luteum.
Uh, no, the corpus luteum will be maintained by HCG, and that corpus luteum will secrete progesterone. So why
By
is
preparing the
progesterone
uterine
that
lining,
important for the maintenance?
yeah, by preparing the uterine
Okay,
lining for
and
implantation
that
and
is one thing.
suppressing
It
the uterine
basically protects
contractions to
the
prevent the
Decreases
preterm labor.
contraction.
Exactly.
Guys,
Yes,
instead of
exactly.
talking
So the second thing,
about there's
it
so
decreases the contractions. So whenever there will be increased estrogen, it will cause a lot of contractions. And whenever there will be contractions in uterine wall, that will lead to the loss of pregnancy. So that is an important thing to remember that whenever there will be contraction of uterine wall, there will be loss of pregnancy if it occurs early in the course of pregnancy. That leads to a pharmacological thing that you need to remember is that we can give drugs that so for abortion, what kind of drugs do we can give in early stage of pregnancy?
We Misoprostol. feel Western
Progesterone,
Misoprostol.
mesoprostol.
oxytocin.
Exactly. So what does prostaglandin? Misoprostol is a prostaglandin analog, and misoprostol will lead to the contraction of the uterine wall. Okay.
Contractions of the uterus. Yeah.
Misoprostol leads to the
Mhm.
contraction. And whenever there will be contraction of uterus, it will lead to the abortion. Second
Preterm
thing,
labor.
the
Yeah.
yes. Second, the most important drug that we can give for abortion is mifepristone. What is mifepristone?
it's
It's
a
it's
progesterone.
basically a progesterone antagonist. Yes, exactly. So it's a progesterone antagonist. So we give mifepristone, and that leads to the increased uterine contractions, and then that will lead to uh, the loss of pregnancy. So another important thing is that where is corpus luteum situated? Where is it present?
Ovaries.
Okay, ovaries. Okay.
In the
So let me
ovaries.
give you a scenario. Let me give you a scenario. A woman came to you and she had sudden onset of nausea, vomiting, and right-sided abdominal pain. She was in the fourth week of her pregnancy. And now she came to you and you did an ultrasound and you found out that the blood supply to the right ovary is not present and the pedicle of the right ovary is twisted. And you made a diagnosis of ovarian torsion. So now the surgeons have decided to remove the ovary, and that ovary is okay. So what is the next step that you need to do in this patient's pregnancy?
Giving progesterone.
Methotrexate.
No, no, you won't give methotrexate. Somebody told me that you will give progesterone. That's exactly correct. Why? This is an important question because whenever, uh, so remember, till 12 weeks of pregnancy, that's another thing that you need to remember. I'll start it. Till 12 weeks of pregnancy, corpus luteum will secrete the progesterone. So to,
Yes.
will secrete the progesterone, okay, and HCG. So till 12 weeks of pregnancy, you need the corpus luteum. And if it's gone, the pregnancy is gone. So if the patient is ovarian torsion, you need to give some other kind of source for the progesterone. So you give artificial progesterone. So what happens after 12 weeks? Why don't we need the corpus luteum anymore?
Because placenta.
Because
the
placenta
placenta
takes
take
over
over.
the placenta
Yes.
takes over
So
the
after 12
function of the
weeks,
corpus luteum.
yes. Yes. So after 12 weeks, the placenta will take on the function of corpus luteum. So another important thing that they can give you this kind of a graph. They can give you this kind of a graph, and on this side, there will be picture like this, and on the other side, there will be a picture like this, and they'll just say that this this is placenta and this is corpus luteum, and they will tell you to mark those x's that what does this stand for and what does that stand for. So obviously this will be timeline, or they can ask you what is this point when the placenta starts making HCG. So that would be 12 weeks. So again, the NME or the boards or the USMLEs wants you to integrate your knowledge with the figures, and they want to be you to become a bit creative. So remember, they can give you this kind of a question in a diagram or something like that. Okay. So after that, what happens in week two? So remember, the blastocyst forms into a bilaminar embryonic disc. That's not really important. So it will form a bilaminar embryonic disc, and it will have two layers, epiblast and hypoblast. In the third week, it will lead to the formation of trilaminar embryonic disc, and three-layer will form endoderm, mesoderm, and ectoderm. And now you need to remember that what kind of a layer, what does each layer lead to? We'll get into that in a minute. But remember, uh, in I think 3 or 4 days ago, I told you about Hirschsprung disease. Okay. So in Hirschsprung disease, I told you that the problems is in neural crest cells. And I told you I'll tell you in embryo what happens there. So remember, just about gene, which is known as SHH gene, sonic hedgehog gene. So what's the function of sonic hedgehog gene? So if there are three layers, this is ectoderm, this is mesoderm, this is endoderm. So this is the ectoderm layer. The sonic hedgehog gene will cause this ectoderm layer to become the neural plate. Okay. So this ectoderm will become the neural plate. which will then give rise to neural tube. So this neural plate basically becomes a neural tube. And you all knows, or you guys all know, what is this neural tube? What does this neural tube become in the adults? Any idea?
Formation of the
Brain and
brain and the
spinal.
CNS
Yes, and
neurons.
Brain and
spinal cord.
spinal cord.
Yes,
Yes,
yes.
really good
Is
and right
this, remember,
synapses to
remember,
sites.
this neural tube will become the CNS and PNS. So remember, this is mesoderm. Sonic hedgehog gene will cause the mesoderm will give rise to a thing known as notochord. And from notochord, neural crystals comes and they form the peripheral nervous system, which is known as the PNS. And then this
So,
notochord, via the sonic hedgehog gene, causes its ectoderm to form a neural plate, and
Anupam,
that
just give
neural
me a
plate
second.
will form the CNS. CNS. Okay. So again, remember, ectoderm is formed by the neural plate, and the neural crystals is formed by the midline mesoderm, which forms the notochord, and that will cause the PNS formation. Okay. Again, so what happens with the 4 weeks? In the 4 weeks, four limbs. So remember the mnemonic four. In the 4 weeks, four limbs will form and four chambers will be formed. Four chambers of the heart and four limbs. And this is the time when the transvaginal ultrasound can detect a cardiac activity or a fetal heartbeat. Again, and the last important thing that you guys need to know is the 8th week. Why is the 8th week important? Because at the 8th week, genitalia are formed. So this is the week by which you can find on the ultrasound that whether the baby is a male or a female, because they will have a male or female characteristic. So they can give you a question, they can ask you that a scientist want to find out that if the baby born, or a physician wants to find out if the baby born is a male or female, and he's waiting for a certain week for that to happen. And which week will it be that it needs to happen? So that will be the 8th week that it needs to happen. Okay. So now we need to know about what lead to what. I'll give you a simple uh, idea about it so it won't become so hard for you. So first of all, we'll start from the easiest thing, that is endoderm. So all the inner lining of the bodies, all the inner lining of the bodies. If there is any hollow tube in the body, can you tell me about the hollow tubes that are present in the body?
Esophagus,
Human
esophagus,
Small
anal canal,
intestine, colon,
vaginal
esophagus.
canal.
urine,
Yes. So the whole
Urethra.
Hello?
Sorry to
gastrointestinal
interrupt.
tract, the whole
the
Mhm.
whole.
Sorry to interrupt.
gastrointestinal tract.
And you
Hello.
Yes.
Okay, sorry to interrupt. Please, those who want to answer the question, please raise your hands one by one because like some of the students are getting disturbed. So please just do cooperate and raise your hands before answering your question. Okay. Thank you so much.
Okay. So remember the GIT tract, the urethra. Again, urethra is a tube. The distal vagina is a tube. The lung structures, the bronchi, the bronchioles, the alveoli, all of them are a tube. So any tubular structure, the gallbladder have ducts, the liver has ducts, the eustachian tube has ducts, thymus has ducts. So all of those things which have ducts or tubes, they will be formed by endoderm. That is a very simple way of remembering that what will be formed by endoderm. You don't need to mindlessly cram that what will lead to what. Just remember the GIT, any tubular structure, whether it is lung, liver, pancreas, gallbladder, anything which has a tube in it or epithelium in it, it will be formed by endoderm. Okay. Now let's go to ectoderm. So I already told you that CNS is formed by the ectoderm. So remember that CNS will be formed by ectoderm. And then there will be two parts of ectoderm. The first one will be neural tube. So neural tube give rise to CNS. So CNS will include brain, and spinal cord and even retina. They all are a part of CNS. So remember brain, spinal cord, retina, any neuron of CNS, oligodendrocyte, all the cells of CNS which you have read will be formed by neural tube. And neural crest cells, which they will give rise to all forms of PNS system. So just remember what is formed by the PNS that you have remembered in the anatomy of neurology, and you will come to that like melanocytes, odontoblasts, all the PNS ganglia, even the adrenal medulla, wherever the neural crest cells go, they will form part of PNS. So just remember what does PNS consist of? What does the other part of other part of nervous system consist of? And it will be formed by neural crest cells, and neural tube will form the simple thing. Now we'll go to surface ectoderm. In surface ectoderm, just remember, like mainly you need to remember that the skin and all the outer parts of body will be formed by the surface ectoderm. That is usually enough for the surface ectoderm. And for mesoderm, just remember the things which are left behind by these two, which will be the things that will be formed by mesoderm. So that is a very simple way to remember. Now is a very high yield topic. The above thing wasn't really high yield, so let's move on to the high yield topic. Is teratogens. They love to test you on teratogens. Not only in step one, step two, step three, wherever you go in your residency, whenever you're practicing, they will love to test you on teratogens. So the number one teratogen that you need to remember is that. So okay. So they won't just ask you about the teratogen. They will just give you a weight condition and they will ask you that the woman was going. So first of all, I'll give you associations, and you can tell me, woman can treat it for blood pressure. Anyone, what teratogen can you think of?
ACE inhibitors.
ACE inhibitors.
ACE
Yes,
inhibitor are
yes, yes. So basically, it will be ACE inhibitors. Now, tell me, what is the name of the condition ACE inhibitors lead to?
Angioedema.
Oh, sorry.
No, anything.
Oligohydramnias.
Otis.
Yes, but there is a proper yes. Yes, exactly. So remember,
Yeah.
ACE inhibitors causes, first of all, ACE inhibitors will cause the renal function to decrease, the renal secretions to decrease. So how do oligohydramnias happen? The renal secretions of baby will decrease. There will be no urine output. When there will be no urine output, there will be oligohydramnios.
Yes.
So when there is oligohydramnias, there will be no cushioning effect which will be present. Okay. So when no cushioning effect is
Yes.
present, the the limbs need amniotic fluid to form. So if the limbs and the lungs, both of these things need amniotic fluid to form. So when there is no amniotic fluid present and there is oligohydramnias, it will lead to pulmonary problems. It will lead to the problems of limbs. It will
Hypoplasia.
lead to the problem, yes, and it will lead to renal failure. So that is how Potter sequence occurs, and that
Potters.
you need to remember that. Okay, so how can we prevent this thing? How can we prevent Potter sequence? So for Potter sequence, you need you guys need to remember that we need to give the following antihypertensives to the mother. Remember, guys, it's not just reproductive, it's not just the embryo of reproductive. It leads to nephrology, it leads to pulmonology, it leads to CNS, and then it leads to preventive medicine as well. So remember, whenever uh, whenever there is a question of water sequence, you just need to remember as well that what conditions or what medications will you need to give the mother in order to prevent the water sequence. So we give nifedipine in pregnancy. We can give labetalol. We
Labetalol,
can
yes.
give, hy- yes, we can give hydrolazine. We can give
Hydrazine.
methaldopa.
And Dopa, yeah.
Okay. So these are the antihypertensives that we give in pregnancy, and you won't give any other antihypertensive in pregnancy. Remember, labetalol is IV that we give in pregnancy. So is hydrolazine.
Mhm.
Methyl-dopa is not usually preferred. So nifedipine is a calcium channel blocker, and this is given in oral form.
Sir, like most likely, mostly they give hydrolazine, right?
Yes.
Remember, okay, so let me tell you another important thing. It depends on the situation. So if there is any hypertensive emergency, which means there is preeclampsia, which is severe, and and the patient is in the hospital, then we have to give some IV form of hydrolazine or labetalol. Okay, another important cardiology tidbit here. Uh, what is the effect of hydralazine on heart rate? So
Release the
how
heart
do we
rate.
decide that how do we decide that we have to give whether we give hydralazine or labetalol in a hypertensive emergency situation?
Bradycardia.
Remember, it's very simple. Hydralazine causes reflex tachycardia. It's a very bad side effect of hydralazine.
Yes.
Okay. Remember, it's a side effect of hydralazine that they test in exams. Hydralazine, nitroglycerin, all of the vasodilators of the body will cause reflex tachycardia. Whereas labetalol is a beta blocker and it causes heart rate to bradycardia. It will cause the heart rate to drop. So if you guys need, so if the patient in the vignette has very high heart rate, it's already 120 or 130, which drug will you guys prefer?
Labetalol.
Labetalol, yeah, beta blocker.
Yes. And if the heart rate is like 60 or 70 or 50, then you guys move on to the hydrolazine. So that's how you decide. And in normal situations, if it's normal hypertension and there is no urgency of a medication, then remember the answer will always be nifedipine and it will be a calcium channel blocker. Another question, where does the nifedipine act on the body? Does it act on the heart or does it act on the vessels or does it act on both of the above?
Vessels.
On the vessels.
Yes, yes, remember it's a dihydropyridine calcium channel blocker. Again, another important thing that you'll have to test is where does nifedipine act? So nifedipine will act on vessels, deltiazem will act on both, and verapamil basically acts on heart. So keep this distinction in mind. Okay. So again, after that, uh, another drug that they love to test is okay. So let me give you a vignette. So a 45-year-old female, 25-year-old female comes to you, and she had a baby which was recently born. In the pregnancy, she had acute onset of vomiting, fever, right flank pain, due to which we gave that woman some antibiotics. But after the baby has been born, the baby cannot hear anything, and the results of the hearing test show that there is sensory neural hearing loss. What were the thing with which the woman was treated?
Minoglycosides.
Yes,
Minoglycosides.
so
Yeah, or toxicity.
aminoglycosides. So yes, aminoglycosides. And what was the condition that the woman was being treated for?
Um,
Acute onset of
Acute
vomiting, fever,
acute
and
cholecystitis.
no,
But hyperemic
Appendicitis.
well, let me write it for
gravidarum.
you.
What?
Hyperemesis gravidarum.
No,
Pyelonephritis.
vomiting.
What?
Yes, it's pyelonephritis. So remember,
Yeah.
uh, mm, so whenever whenever there's flank pain, vomiting, and fever, this is a classic triad for pyelonephritis. And whenever you see pyelonephritis, always think of sensorineural hearing loss because we give a lot of aminoglycosides in pyelonephritis. So if we give aminoglycosides in pyelonephritis, it can cause sensorineural hearing loss. At the same time, we give a lot of fluoroquinolones in pyelonephritis. Okay. So another drug interaction here. What if the woman had vomiting fever and right flank pain, all these things, and the baby has problems in his ankle or Achilles tendon and the tendons of his body? What drug was the woman given?
Ciprofloxacin. Fluoroquinolones.
Yes, the fluoroquinolones. Again, remember, whenever there's pyelonephritis, you have to remember these drugs. You have to remember these drugs that aminoglycosides will lead to sensorineural hearing loss and fluoroquinolones will lead to some kind of cartilage damage. And another high yield fact is that fluoroquinolones can also lead to aortic aneurysm, aortic dissection. It weakens the cartilage of the aorta and that can lead to aortic dissection. And it happens in old who are smoker and hypertensive, and then you give them fluoroquinolones for the treatment of pyelonephritis or a urinary tract infection. It will lead to aortic dissection. Okay. After that, a woman, the baby. Okay, so let me tell you, a baby is born with a cleft palate. What teratogen comes to your mind?
Is it phenytoin?
Isotretinoin.
Isotretinoin.
Yes, it
Yes.
will be. Yes, it will be isotretinoin. And what drug?
Like
Vitamin
like
A.
acne and drugs for the acne treatment.
No, no, I'm sorry. I meant to ask what gene is causing this?
Is it vitamin A supplement?
It's Hox gene. We just studied it. Hox gene. So homeobox gene will lead to this problem. Okay. So now the baby is born with, I would say, hair at the back.
Mm.
So there are tufts of hair at the back of the spinal cord. What are you thinking now?
Yes. Neural
Spina
defects.
bifida.
Spina bifida.
Hmm?
Spinal
Yes.
bifida.
So what drugs are you thinking about?
The lack of
Folate antagonist.
Yes. So any anti-epileptic drug will cause this. How can you prevent? How can we prevent this problem?
Folic acid supplements and
Yes.
avoiding these
How many grams?
Before pregnancy.
How many grams? So it will
500
be
5,000.
so it will be a 5 mg, 5 mg folic acid, which is high dose folic acid supplementation, should be given to those which are at high risk. So basically, these people are at really high risk. So we use high dose folic acid supplementation. Okay. Now, let me tell you about two other things that are really important. Okay. So what happened in 1940? Uh, so this is a really interesting topic. So in 1940 to 1970, a drug was used for getting women pregnant. Basically, it was an estrogen. It caused pregnancies and it prevented miscarriages. So a lot of it was given to the women. It was really
Diethylglycerol.
widespread.
Diethyl.
Yes,
Mm-hmm.
silbestrol. So it was diethylsilbestrol, and a lot of women were given these drugs for pregnancies. But what happened was that whichever women were given these drugs, the babies had vaginal clear cell adenocarcinoma. So vaginal adenocarcinoma. Another important thing here is you guys haven't read about the patho portion yet, but let me tell you this thing. There are how many types of vaginal cancers are there? Anyone? So there are two types of vaginal cancers.
Squamous cell cancer and
W-
adenocarcinoma.
Yes,
Yes.
yes. So it is squamous cell carcinoma and it is adenocarcinoma. And what is the most common cause of vaginal cancer?
HPV.
Yes, it's the squamous cell version and it's caused by HPV. But remember, guys, you have to see the question carefully. A lot of time, the NDME and the USMLEs, they are trying to trick you. So how they will trick you? Basically, they will give you a diagnosis of a vaginal cancer, and they will mention that in the biopsy or in the histopathology, you can see that some of the cells have clear cytoplasm in them, or the cells are clear, and there is no cytoplasm in them. So that means that the patient is having clear cell adenocarcinoma. And below that, they will say what is the causative organism or what is the causative thing that is leading to this cancer. And all of you will think that HPV causes vaginal cancer, and so it's a very simple question, and let's just go with HPV. But no, you have to see whether it is HPV or whether it is the squamous cell version or the adenocarcinoma. In the squamous cell version, the histopathology will show keratin bridges,
Pulse.
keratinization, keratin pulse, all of these things will be present. But in the adenocarcinoma, the cytoplasm will be clear and it will be a clear cell adenocarcinoma that will be caused by diethylstilbestrol. So always check that whether it is diethylstilbestrol or HPV that is causing that cancer. Okay. So now another important thing is Epstein anomaly. Okay. So remember, let me give you a scenario. A woman is hyperthyroid and she's in the first pregnancy, first trimester of her pregnancy. What drug do we give to this person?
PTU. The teratogen is methimazole.
Thiuracil.
Yes, so we give propyl thiouracil. So what does methimazole cause?
Aplastic anemia also.
No,
Maybe.
it will cause
No.
aplasia
Cutis.
cutis. So
Yes.
basically,
Cutis.
yes. So
Which is the
basically, they
congenital
will give
abscess
you
of the
the
skin.
condition that a skin is absent on the scalp. Yes,
Yes.
no skin on the scalp. So if there is no skin on the scalp, it means that this patient was taking methimazole. So these are the minor differences. Remember, if there is no skin on the back, what drug was the mother taking?
In
Anti-epileptic
the
drugs.
back.
Yes,
Anti-epileptic.
yes. Then
Anti-epileptic. Huh?
yes, then it will be anti-epileptics. So if there is no skin on the back, then it will be anti-epileptic drugs and it will be due to the neural tube defects. But if there is no skin on the scalp, it means aplasia cutis and it will be due to methimazole. And if the question says that the problem is with the eye and there is no skin around one eye.
One
So,
eye.
what is the disease now and what gene is being affected here?
Is it how a person is sexually made?
Yes, it will be holoprosencephaly, in which there will be a single
SHH.
eye, and so the SHH gene will be involved. So that is how they can give you different questions. So, and again, an important thing is that in the second trimester and the third trimester of a hyperthyroid woman, which drug do you prefer?
Methimazole?
Azole.
Methimazole.
Yes, why? Why?
Liver problems because of PTU?
Liver toxicity.
What problem does PTU cause in the second and third?
Hepatotox.
Hepatitis C.
Yes. So PTU, yes, PTU will lead to permanent hepatic failure. PTU leads to PTU will lead to fulminant hepatic failure. So that is why you don't give PTU. So guys, another important thing, in the first state, they say tetracyclines cause discolored tooth and inhibited bone growth. That is true. But remember one thing, the recent guidelines say that you can give tetracyclines in children. You cannot give them in pregnant women, but you can give them in children. Before it was said that you cannot give tetracycline in children's, but now you can give tetracycline, doxycycline, Vibriomice, anything like that in children. So tetracyclines can be given in children, but remember they cannot be given in the pregnant woman. Okay. What is a very important mm, what disease do we give tetracyclines for, in especially in pregnant women?
Mm,
A woman
Crazy.
came, let me give you another vignette. A woman came to you, she went for hiking, and after hiking, she has a rash on her back, and at the same time, she has flu-like symptoms. What is the
Mind
diagnosis?
disease.
Rocky Mountain.
Yes. Yeah. No, it won't be Loki as the patient does not
Lyme
have a
disease.
single rash. It will be Lyme disease. But remember, in Lyme disease, we give Doxy. But if the woman is pregnant, what drug will you give now to that patient?
Triazone.
No, we simply give them penicillin, penicillin, ampicillin, ampicillin or amoxicillin.
Mm.
Okay. So after that, there is another drug which was an antiemetic drug. So in you guys know that in early pregnancy there is a condition known as hyperemesis gravidarum.
Yes.
So uh, which and there's another condition known as morning sickness. So basically, morning sickness means a little bit of nausea and vomiting, which is normal in pregnant women. In 1950s, we started giving a drug which was known as thalidomide for morning sickness and drug. But when we gave this drug, we came to know that the children are now having limb defects. So now we don't give that drug. And again, another disease which causes warfare, which causes limb defects and bone and cartilage defects is warfarin. So if a woman is having DVT in pregnancy, DVT is very common in pregnancy, we will give that patient heparin instead of warfarin. So I think that are the drugs that causes limb defects that you guys need to remember.
Doctor, could you
Okay.
repeat the last part? Which one was the one that caused the limb defect?
So warfarin. So if we
What?
summarize about the limb defects, what conditions can cause limb defects in children? The number one would be FGF gene, and that causes achondroplasia. Okay. So the number one thing would be FGF gene that causes limb defects. After that, ACE inhibitors. But remember, when limb defects happen with some kind of renal insufficiency and pulmonary insufficiency, only and only then it would be caused by ACE inhibitors. Okay.
Yes.
Now again, okay. Now again, fluoroquinolones can cause some kind of limb defects as well. But remember, it will be in a woman who had pyelonephritis and was taking antibiotics for that. After that, thalidomide. Any woman who took an antiemetic and that caused limb defects, that would be thalidomide. So that can cause limb defects. And after that, warfarin can again lead to some kind of limb defects, but that would be in a woman that is being treated for DVT. And remember, whenever you see a patient that is pregnant and that has DVT or some kind of procoagulant, remember, pregnancy, this is a very important thing, is a procoagulant state. There is very increased risk of clots and strokes and DVTs in pregnancy. So if a woman is suffering from any kind of problem in pregnancy, you will any procoagulant condition in pregnancy, the drug of choice is heparin. Remember, you have to get the heparin. Okay. Now, we'll skip the substantial. Okay. Um. Okay. So now let's discuss another important topic. Okay. So having diabetes in mother, what does that causes? What increased risk is at the woman at after having diabetes? Not the baby, but the woman.
Renal failure.
No,
Persistence
it's
of type 2 diabetes.
it's
After
preeclampsia.
pregnancy, it can cause the gestational
So if a
type
woman,
2 diabetes in women.
hmm, but if the woman is having diabetes prior to the pregnancy and she now became pregnant, the most important thing that she is at risk of is preeclampsia
Preeclampsia, yes.
types of diabetes.
Mhm.
Okay, and again, there are two types of diabetes: gestational diabetes and the second one is type 2 diabetes or type 1. So, in which trimester does the gestational diabetes start?
In the third trimester.
Yes. So, it starts in the third trimester versus the type 2 diabetes, which starts in the first trimester. So, we need to divide these in a separate column because it starts in first trimester. Yeah, so, remember, if the good So if the diabetes is present from the first trimester, the baby will have different kind of problems as compared to the diabetes which is present in the third trimester, which is gestational diabetes. So if the diabetes is from the first trimester, the patient will most likely have, and if it is uncontrolled, it will be caudal regression syndrome or heart defects. So these two are the things that you need to look for if the diabetes is present from the first trimester. But if the diabetes is present from the third trimester, which means the patient did not have any diabetes before the pregnancy, and in pregnancy she developed diabetes, then it's maternal diabetes, it's known as gestational diabetes, and for that, the patient will have these kind of problems. It will be polycythemia, it will be respiratory distress syndrome, hypoglycemia, and macrosomia. So these are the very small differences that they want you to know. Because if you see in first aid, they have just mentioned what kind of problems will be present due to maternal diabetes, but they haven't like mentioned that which will be due to third trimester diabetes versus which will be due to first trimester diabetes. Okay, so I think
Excuse me,
guys, today,
explain-
yes.
excuse can you explain the link between maternal diabetes and preeclampsia? Like, how does preeclampsia occurs in maternal diabetes?
Okay. 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 So remember, uh, can you first tell me what causes preeclampsia?
Basically, endothelial dysfunction that and hypertension
Yes.
causes it.
Yeah.
Okay. So remember, what happens is that whenever the body is any kind of oxidative stress or any kind of stress, especially oxidative stress, there will be increased inflammatory
Does it
molecules.
Does preeclampsia caused by the abnormal placental development?
Yes, it's caused by the abnormal placenta development. I'll let you know. Like I'm just explaining how it can lead to the whole thing. Okay. So first of all, remember that whenever there is preeclampsia is due to oxidative stress and inflammatory molecules. How does that happen? Is that in pregnancy, if there is any kind of oxidative stress, if there is hypertensive state, there will be increased molecules which can cause inflammation. And then what happens is that it will lead the endothelium in the placenta to not properly form. And how does that happen? So basically, if this is the placenta, so if this is the placenta, then small spiral arteries need to form. Okay. So we talked about blastocyst. So basically, blastocysts will be implanted here. Okay. And there's blastocyst and cytotrophoblast will invade the small arteries of placenta, and these are known as spiral arteries. So these arteries are known as spiral arteries. Okay. So the cytotrophoblast causes the spiral arteries to become high volume and low pressure arteries. Okay. So it will increase the diameter of these arteries. So more blood flows into this artery and there is less pressure, which is present. But what happens is that when there is any kind of oxidative stress, or especially in diabetes, there is increased blood glucose. The sugar will go to bind with these endothelium vessels, and they will form glycated compounds. So when these glycated compounds are formed, they will cause the arteries not to remodel. So normally in our body, the arteries are high pressure, low volume. Okay. So so they have a lot of pressure, but in the placenta, we need high volume and low pressure arteries. So as to provide maximum amount of blood flow to the baby. So if there is hypertension, if there is chronic kidney disease, if they because in chronic kidney disease you cannot remove the uremia and the urea and the nitrogenous waste. If you have chronic liver disease, if all of these conditions will cause the harmful molecules or the inflammatory molecules to just stick on the vessels, and whenever they are present on the vessels, they will cause the vessel to remain constricted, and they will cause the vessels not to remodel. And when the vessels will not remodel, there will be ischemia of the placenta, as enough blood will not come to the placenta. Okay. When such bloods and so when the blood does not come to the placenta, then placenta will release a lot of different molecules such as FLT1 and SNG molecules. Okay. Now this will cause all of the body to become deranged. All of the body will have decreased endothelial function. There will be increased vasoconstrictors, there will be nitric oxide production, which will lead to vasospasm, and then whole of the body will be affected, and then the kidneys and the liver starts to become affected. So that's how diabetes plays a major role in preeclampsia. And one another important thing is that whenever you have any kind of such problems, high blood pressure, diabetes, CKD, chronic liver disease, family history of preeclampsia, you have to give aspirin to the mother starting at 12 week of pregnancy. That is important. Remember this thing. Now, why do we give aspirin to the mother? Because when a aspirin will basically prevent v- vasospasm, and it won't in preeclampsia. There is production of molecules like SFLT1 and SCNG molecules that will lead to the formation of blood clots, and blood clots can cause dysfunction in the kidneys, liver, and placenta. So aspirin will cause blood clots um, that to not form, and when the blood clots will not form, it will lead to a better condition. So these are the risk factors, and I told you how does that happen. Any other question?
Yes, doctor. What did you mean by PPS in the gestational diabetes one of the effects of it?
I did not get your question.
Could you scroll up a bit to the table between the gestational difference and the difference between type 2
Yes,
diabetes and pregnancy? Yeah. What's the full meaning
yes.
of the PPS you had? Mm.
Oh, it's not PPS, it's RPS. So RDS.
Uh,
So it's respiratory distress syndrome.
Distress syndrome,
uh,
yes.
thank you.
Okay. Okay. So if you want to know about it, it's simply that we need a lot of stress. We need cortisol or any steroid for the formation of lungs in babies. Okay, right?
Yeah. Yeah.
Okay. So remember, basically the treatment of RDS or the prevention of RDS is also that you need to provide some kind of steroid to the baby. Okay. So what happens in gestational diabetes mellitus is that insulin is produced in the mother and in the baby. And an important function of insulin is that it it antagonizes the cortisol. It will cause the cortisol not to function properly. It will destroy the cortisol. So if there is increased cortisol in the baby, increased insulin in the baby, it will cause the cortisol not to work properly. And when the cortisol does not work properly, it will lead to respiratory distress syndrome. So that is why gestational diabetes is a very important risk factor for respiratory distress syndrome. And again, they can test you how does gestational diabetes mellitus leads to respiratory distress syndrome. So whenever there is hyperglycemia, there will be increased production of insulin. Whenever there is increased production of insulin by the mother and baby, that will lead to increased antagonization of cortisol, and then the lungs won't mature properly. And again, that is what will lead to hypoglycemia. Because whenever there is increased insulin, that will cause the blood glucose levels to fall in the baby. Okay. Any other question?
So, doctor, there is something related like the baby's pancreatic cells become hyperplastic because of
Yes.
the placental flow of the
Hmm.
glucose. So the
Yep.
yeah, something like that.
Yes. Exactly. Does anyone have any question? Okay, so we'll call it today, and tomorrow we'll complete the embryology, and then we'll move on towards the pathology, and we'll complete it in a day or two. Okay.
Thank you, doctor.
Thank you.
Thank you.
Thank you, doctor.
Hello? Hello?
Hello.
Okay.
Yes, doctor.
Okay, okay, are you guys just enjoying your sessions with Dr. Muaz?
Yes,
Yes.
doctor. It was really awesome.
Yes.
That's perfect. Okay. So we have started our registration for research, as most of you guys know. So those who are interested, so one of our batch is completed, batch of 10. So those who want to just avail their position, so yes, do contact Dr. Hamza for that. Okay. Thank you so much.
How should what should be the payment method, doctor? Can you
Okay,
share?
so for now onwards, like for now, we are just checking on Zell, and like within 1 or 2 days, we'll just show the Stripe. So we have like multiple option available. If someone is from India, so we also have like ambassadors there. You can just transfer it to Indian account or any other. If someone is in US, they can just do Zell. If someone want to do it through Stripe, so every payment method is available. Okay.
Okay, doctor. Okay.
Okay. Thank you so much.